Dear colleagues, this is the OpSens supported breakout session of the TIO 2024 program. It explores this new concept of sensor-guided TAVI, and I'm joined by my colleague Rutger-Jan Nuis from Erasmus University Medical Center, and the Regueiro from Hospital Clinique in Barcelona, and my good friend from Jerusalem, Dvir. We will start off with a poll, and then Ander Regueiro will present on optimizing LV pacing in sensor-guided TAVI interventions. And as we're doing all that, please feel free to ask questions or comment or make comments, and then we can also deal with these questions and comments during our panel discussion moments. So after the first topic by Ander, we will proceed with Dvir, who will then present on potential benefits on continuous pressure gradient measurement during TAVI in specific clinical settings. But let's first start with this first poll question. And the question is, what specific enhancement would improve your TAVI procedure workflow and efficiency most, beyond what your current TAVI guide wires currently offer? Is it a different kind of stiffness? Is it a different shape? Is it more reliable and safe LV pacing capability? Or is it the aspect of continuous hemodynamic measurements? So we'll look at the results after the presentation from Ander. So therefore, we first switch to Ander Regueiro for his presentation on the use of this new TAVI wire technology. Ander, over to you.
It's a pleasure to be here, and thank you very much for the invitation. So we'll go through this part of the session, speaking about LV pacing and the main advantages of it. So why do we need LV pacing? Well, as you know, and this is a picture that we have been looking a lot during the last weeks, because as you all know, this is Dr. Dvir who started all this TAVI revolution more than 20 years ago. Unfortunately, he passed away recently. So, but this is how it started. It started a little bit more than 20 years ago, and it has increased in there has been a really good increase in terms of technology and evolution and numbers of procedures. So it all started there. And now, as you can see, the numbers has increased, particularly in the US. This is also a graphic in which you can see that TAVI is now an option, and it's not only an option for very elderly patients with very high surgical risk. Actually, we are treating patients younger with low risk, so we really have to optimize the procedure and make it safer. And to do that, we will need to evolve. So as you can see here, also this is not only in the US. This is data from Europe, in which you can see that the increasing number of TAVI has been quite amazing during the past years. So right now, actually, in terms of the guidelines, TAVI is recommended as class 1 for patients with aortic stenosis who are older than 80 or 75 years old, and also for younger patients in which surgical risk is high. So why do we have this revolution? Well, we have increased the number of procedures, and we have increased the safety and efficacy, because we are now adopting tools and techniques to make this procedure safety, more efficacious, and trying to minimize interventions. And how can that happen? Well, that can happen because you can have an idea and then try to put it on to try to minimize the interventions and to evolve. So giving you one example, sometimes you have an idea, for example, this one in which they try to avoid a pacemaker for patients undergoing TAVI with the administration of adenosine. So you have this idea, you try it, and if it doesn't work, then you just simply move on. But there are some times in which the idea can actually evolve. So as you can see here, this is a paper for almost 40 years old, in which the authors consider that it can be safe to pace a patient without any pacemaker and doing the pacing through a coronary angioplasty wire. So that idea, as you can see here, is kind of old. So you take that idea and try to evolve with it. So the next step will be to do the same procedure, but not on coronary angioplasty, but on balloon valvuloplasty. This is in 2009. And if you move forward, the same idea, 40 years old, actually was tested in 2013, in which you can pace a patient without pacemaker using the left ventricular wire. The first experience was published, as you can see here, in 2013, but now we have plenty of experience. So in Europe, there are several registries. This one, for example, is from 3 French centers in which they use this new LV pacing idea to pace 38 patients with valvuloplasty and 87 patients undergoing TAVI. And they saw that it was very effective. 100% had a significant reduction of the pressure, and with only 1 case of valve embolization. And also, in patients in which develop conduction disturbances, they put a venous pacemaker without any issue. And on the other hand, using a right ventricular pacemaker, they saw 1 case of cardiac tamponade. So this is the French registry. That was the French registry. This is one registry from the UK. As you can see, there are plenty different registries. So this is one of them, but we also have the experience from Oxford and several registries, and not only from the UK. There are registries also from Poland, and one of the director of the meeting today from the Netherlands. But we also have data coming from randomized clinical trials. This is the EASY-TAVI trial, in which they randomized 300 patients to go either LV stimulation or RV stimulation. And as you can see on the numbers on the right, the LV stimulation was associated with a shorter procedure duration, with less use of fluoroscopy, and a reduction in cost. And this was also accompanied by the same efficacy and safety. Because the number of patients was kind of limited, they did not see any differences in safety, but actually the only 2 patients that had a cardiac tamponade were patients who were randomized to RV stimulation. So as you can see here, the LV stimulation is associated with a short-term procedure time, less fluoroscopy time, cheaper, and with the same safety and efficacy. And moving on, we now have a wire that is specifically dedicated to do this. So this is a dedicated TAVI wire, the SAVI wire, which is a pre-shaped wire used to deliver the TAVI, that has also 2 other characteristics. The first one is that this wire has an electrical isolation. As you can see, the orange part of the wire, just after the end of the shape of the curve of the wire. And it has 2 spots to put the pacemaker battery to do pacing through the wire. Another particular characteristic of this wire is that at the end of the curve, it has a fiber optic sensor to measure live the LV pressure. This wire is intended to give you good performance, to pace the patient, and to measure the pressure during TAVI deployment. The first experience was published by the group of Joseph Ruiz in Canada, and we also have data from the SAVI trial that was a multi-center registry with 8 centers in which we measure the efficacy of this wire. The primary endpoint was the reduction of the systolic pressure below 60, and the primary endpoint was actually achieved in more than 98% of the patients. So we now know that the SAVI wire can actually be used to pace patients in a very safe and efficacy manner. But there are some tips and tricks that people need to know when they are doing LV pacing, because if you follow these steps, the procedure can be very safe. So first of all, before putting any wire inside the LV ventricle, you need to, left ventricle, sorry, you need to have all the equipment prepared, because sometimes just crossing the wire, the patient develops conduction disturbances. So if you don't have ready your equipment, you can have bad time there. So prepare all your equipment, have the battery and the cables of the pacemaker ready before going inside the ventricle. After that, you can close the valve and advance the valve, the wire, and you need to be sure that the wire is completely free and really well positioned into the apex of the left ventricle, as you can see here. Then you have to connect the wire. So as you know, this kind of pacing is a unipolar pacing. So you have to put 2 clamps of the battery of the pacemaker. The negative or black will go into the wire, and the red one will go into the skin of the patient of the positive. There are several ways to do this. So some tips and tricks. The first one is that sometimes when you put the clamp on the wire, the negative or black one, if you are using clamps that have been used several times, you don't have a really tight connection. So if you are using cables that are new, there is no issue. But if you are reusing your cables, then you can put a clamp on top of it to be really, really tight. So that's one thing that you can do. And on the other hand, on the other part of the cable, the red cable of positive, this is the standard way to do it. You just put a needle through the skin of the patient and put the clamp. However, sometimes this can be painful for the patient. When you do the LV stimulation, the patient can have a little bit of pain, and sometimes you can have a little bit of bleeding. So there are other ways in which you can do this. So another way will be to connect directly the clamp into this incision of the TAVI. In this way, you won't have any bleeding, and actually you avoid any pain or uncomfortable moment for the patient. If you don't have clamps, then what you can do is just directly connect the back end of the wire with a needle. And this is an alternative in which you can also do this kind of procedure without the clamps. So after you're happy with that, you need to pace the patient and see that the pressure actually drops. And as you can see here, this part in the middle of the video is the optomonitor. This optomonitor is specific for the TAVI wire, and you are looking at the white pressure, which is the pressure inside the ventricle that is very measured with the TAVI wire live. So you start to pace, and you can see that there is a pressure drop. So you can confirm that you can go through. And the other part during valve implantation that you really have to be aware, as you can see in the video on the bottom part of the right, my hand is holding the wire. This is a very important thing to do, because you really want to avoid that the wire moves during deployment, because if the wire moves, then you can have a loss of capture and valve embolization. But if you hold the wire softly to the apex of the left ventricle, it will be okay. Sorry. Okay. So the steps for doing the LV pacing, you will see that you need to cross the valve first. Then, after crossing the valve in a standard way, you need to connect the wire. You're looking at the bottom part of the video. You position the catheter, and you advance the wire in the standard way. This is using the TAVI wire. You will see that the wire is completely free. So if you are happy with that, you remove the catheter, the AL or the pigtail catheter. and then advance either the balloon for valvuloplasty, or you can advance the TAVI. In this case, we are doing a direct implant of a sapien valve. So you put the valve inside the wire, and you will see on the right upper part of the screen, right now you're looking at the red curve, that is the pigtail aortic pressure. But as soon as we advance the valve, we will connect the back end of the wire into the pressure sensor of the TAVI wire, and you will see two pressures. There you go. The white pressure is the pressure inside the ventricle that is being measured with the TAVI wire and the optomonitor. Then you start to pace. If you're happy with the pressure, then you can deploy the valve. As you can see here, there is a good pressure drop, so you deploy the valve. And one of the beauties of this wire is that actually after deployment, you will see, you remove the delivery system, and the pressure sensor is just above the valve now, because we retrieve a little bit the wire. So you look at the white pressure is the pressure on the wire. You equalize the pressure with the pressure of the pigtail, and then you just advance a little bit the wire, and the sensor pressure will be inside the ventricle. So you have immediately, after deploying the valve, the measurement of the gradient. Then with the help of the optomonitor, you can compare the pressure before and after the procedure. And then if you're happy, you're done with the TAVI. You will see, you do the final angio, and then you compare the pressures before and after the procedure. So why do we need LV pacing? Well, we need that kind of procedure because it can minimize intervention and improve safety and efficacy. And now we can do that with a dedicated guide wire. Thank you very much.
Thank you very much, Ander. That was a great presentation. Maybe to get started, what was the poll result? So can we bring up the results of the poll first? So we were questioning, what would you want in a new wire for your TAVI procedures? Do you want to have more stiffness? Do you want to have more shapes? What about pacing capability? Well, and the majority of the audience, they are really looking for the ability for continuous hemodynamic measurement. Is this something that resonates with you? Is this something what you would look for?
I think we will hear that back in the next lecture, which is on hemodynamics more. But I think if we especially start off with transcatheter aortic valve implantation in native anatomies, but also in the specific situations of valve-in-valve procedures where you have a higher risk of prosthesis-patient mismatch, I think it's very important to monitor the hemodynamics and also to look for the AR index, which indicates what the AR severity is. So I agree with that, because that this is the most, to me, that's also the most important feature of this wire.
Mm-hmm. And there was also a significant proportion of the audience that was a little bit concerned about the pacing capabilities. Is this something that we encounter in our practice? Maybe you can comment a little bit, because we are also systematically pacing on the LV wire.
Exactly. So in our practice, indeed, we pace on the LV wire using a standard pre-shaped wire for transcatheter valves. It's a Safari wire in our case. And I think our failure to have capture rate is less than 0.5%. Mm-hmm. But I have to admit that at times we also have to do some some extra tricks to get a good capture. And so this is also my question to Ander. Do you have any experience in LV pacing over a standard wire versus the TAVI wire? Are there any differences? And if there are any differences, how would you encounter this issue?
Yes, well, I mean, we can divide here LV pacing from RV pacing, and then LV pacing with Safari versus LV pacing with the TAVI wire. So we are also doing all of our cases with LV pacing. I think now it has been demonstrated that this can be safely done and actually reduces time. And first of all, well, you need to identify those patients in which you are probably will have a problem. So for example, we are not doing that on patients with RVV, right ventricular branch block. But other than that, we are doing that systematically. And in terms of LV pacing, I think it's very, very important to have a really good position of the wire in the apex and that the wire is stable. And also to be sure that the grounding is correct. There are several ways to do that and several different methods, but the important thing is to be sure that the grounding is correct, that the clamps that you are using are working well and all the connections are fine. And also, I mean, there are people who are using a threshold to define if the pacing is correct, but in our practice, we just go with max output and pace the patient. But when we compare the Safari wire with the TAVI wire, there are some differences. One of them is that with the TAVI wire, you don't need any catheter to pace. You don't need to isolate the wire with any catheter. So if you just put the wire inside the ventricle, then you can immediately pace the patient. That's one of the main advantages. The other advantage is that it has two connections. So one at the very back end of the wire and another in the middle. So if you start to pace the patient and the patient develops a conduction disturbances, you can remove the delivery system and then switch the cable into the other part of the wire, so you don't lose pacing while you do this kind of maneuver. And the third thing is that, and this has been measured, it hasn't been published, but if you measure the thresholds in which you can pace with these wires and compare that with the commercial available wires, the threshold of this wire is lower. Then it's actually better because it's dedicated pacing wire. So I would say that are the most important differences.
Thank you very much, Ander. I think that was a very good answer, and also it responded to quite some comments made by the audience already. So let's move on to the next part of this symposium, and let's do that again with another poll question. So in which scenario would continuous hemodynamic measurement through the guide wire be most crucial during your TAVI procedures? That is the question. Is it for all TAVI procedures? Is it specifically for valve-in-valve procedures? Is it for TAVI and small aortic annuli? Or is it with BAV or with aortic leaflet modification? So please think about it, and then we'll discuss the results of the poll at the end of the presentation by Danny. And Danny Dvir has probably one of the largest experiences with using SavvyWire in more complex TAVI procedures. So Danny, over to you for your overview.
Thank you so much, Nicolas and friends. It's a great pleasure to join this fantastic session. And I can go forward here. So I'll focus mainly on the hemodynamics part of the wire. So we can look at hemodynamics at different stages of the TAVI procedure. We can look at it at the baseline. We can look at it after we do predilation, during partial deployment of a self-expandable valve, before doing post-dilation, if we decide to post-dilate, and obviously at the end of the procedure. And maybe I'll try to be more succinct and quick because I have many interesting cases to show you. So the wire allows for immediate pre- and post-implant comparison and without device exchanges, no need for a pigtail. In sheathless systems, you do not need to bring the sheath back. And I must say that for us that are doing for many years a lot of TAVI procedures, this is a great advantage. It really allows for understanding what's happening in the left ventricle, because that was a missing part in our TAVI procedures. We do not know what is the what's happening in the LV, what is the AR index during our procedures. And this is the display of the monitor, the opto monitor display. You can see live the LVEDP, the gradient across the valve, and the AR index. And if you wondered whether the numbers that the wire gives you are accurate, it was studied and published, a comparison between the wire and regular pigtail evaluation. And I'll just say that it showed in Bland and Altman statistical analysis that the difference is almost zero. The wire gives you the LV pressure accurately. So we go directly to case examples. And actually the first case, in order to save some time for discussion, I'll go through it quite quickly. I wanted to show that the wire allows good support because I described a case that really required supportive wire, a lady with morbid obesity and a lot of tortuosity. These are the baseline hemodynamics with mean gradient of 35, AR index of 31, and afterwards, the deliverability was good, and maybe I'll go directly to the end result that shows that comparison. Mean gradient of 10 after implantation, AR index of 28. We're happy with the result. No need to bring the sheath back to bring a pigtail and to understand the result. Case is done. The second case is a BAV case. I wanted to show a BAV scenario. It's a lady, a 68-year-old, that was admitted to internal medicine with gram-negative bacteremia. Unfortunately, that lady had pulmonary edema, severe renal failure, and they understand that that lady not only has sepsis, she has severe aortic stenosis, mild AR. During bacteremia, obviously, TAVI is not appealing, and she's coming for balloon valvuloplasty. This is their baseline, mean gradient of 45, AR index of 13, which is quite a concern for us. So we did a gentle pre-deal with a 14 millimeter balloon. We did it twice. Mean gradient stayed almost the same, 30. AR index is still very bad. So no need to bring back pigtails and to understand we are not effective enough. So we go ahead and escalate to a larger balloon. This is a 20 millimeter balloon that you could have chosen it from the beginning. We do our first pre-dilation. Mean gradient is still not good. It's still 30. AR index is the same. We do another run of pre-dilation. And after that, fortunately, the mean gradient now decreased significantly. AR index is about the same. We didn't inject. We went in with the echo, so the not TE, TTE, to understand that indeed we're happy with the result. Case is done. So it really allowed for a more effective, and I think to myself, a safe balloon valvuloplasty procedure. So this is a display of pre and post. We'll go to the next case. An 80-year-old lady with severe aortic stenosis coming for a Navitor procedure. So there are procedures, like in Navitor and Accurate, where we almost routinely do pre-dilation. In these situations, I like to use the TAVI in order to understand that I was effective. Sometimes our pre-dilation are not so effective, and we just say, oh, we did balloon. But no, I want to understand that I did something. So it is helpful to understand. Now the valve is coming and being deployed. And after that, we look at the result. Mean gradient, very low. AR index above 25. I'm happy. No need to bring the sheath back to the patient. Case is done. The next case, 76-year-old male coming for a SAPIEN 3 procedure. That person had more than the average calcification of the aortic valve, also some LVOT calcification. It's not routine for us to do a pre-dilation in SAPIEN procedures. I decided to do. And later on, I deployed less than the conventional oversizing of a SAPIEN procedure. I think that doing a stepwise SAPIEN implantation in cases with LVOT calcification, heavy calcification, could be advantageous, because if I know immediately that the AR index is not good enough, I'll just bring another CCO2 back and inflate again. So this is what I did. I thought that the AR index is not good enough. I inflated a bit more. AR index is now good. Good result. No mechanical injury. Case is done. I really think that for different scenarios, the TAVI wire can streamline TAVI procedures. The next case is a patient with a prosthetic mechanical mitral valve, a complex patient coming for TAVI. I think that in many cases with a potential for LVOT gradient, suicide ventricle, this situation, I want to understand what is happening in the left ventricle live. The LVEDP, I want to understand what is the gradient across the LVOT also, not only on the aortic valve. So this is the pre-dilation. I monitor the hemodynamics throughout the procedure. Later on, the TAVI is implanted. No stacked valve. AR index is good. Case is done. Mean gradient decreased from 62 to 18. AR index afterwards is above 25. I'm happy. Finished. The next case is something that we see occasionally, a patient with a significant renal dysfunction coming for TAVI. We want to do minimal amount of contrast. That patient, if I'm not mistaken, even didn't have a contrast CT. So we really focus on doing hemodynamic monitoring during these procedures, because they are also prone for PVL, because we don't know the sizing well enough. Balloon valvuloplasty, and later on, TAVI implantation. Although it's not expanded well enough in RAO caudal, the AR index is nice. It's above 25. No gradient. Case is done. Mean gradient decreased to 4 eventually. LVEDP was low. We're happy. Nicolas, I wanted to finish with 2 complex procedures. Basilica procedures. I think that now we do more and more leaflet modifications, and there are also dedicated tools that we advocate for. I think that we cannot do safely these procedures without understanding the LV pressure, because it can say a lot about the AR situation. It can tell us about if the LVEDP is rising, whether there is coronary obstruction. So here you can see a patient with Magna is a small, only 19 label size. Unfortunately, I cannot imagine why they put such a small valve, but this is what they did. With the mean gradient of 88 across the valve, AR index is reasonable at baseline, at risk for left main obstruction, obviously. So extreme stenosis, mean gradient of 88. So before we do anything, just to give the heart a breathe, pre-dilation, gentle pre-dilation of 8 millimeters, did nothing. A more robust pre-dilation, still very gentle, 10 millimeter. It did something, okay. So we go ahead and do basilica. That was fortunately straightforward. We lacerate the left cusp and look at the hemodynamics immediately after. Stenosis maybe a bit less. AR index above 25, okay. The patient is not having dramatic aortic regurgitation. We can just continue and do, even I did protection to the left system Not sure why, but I did. Left system wire protection. And then I brought the volute. So we started with mean gradient of 88. Now the mean gradient is 20. AR index is okay. LVDP is a bit slightly elevated. It's not good enough for a relatively young patient. Then we do ring fracture. And afterwards, we see that the mean gradient decreased dramatically. AR index is nice. Coronary flow is good. LVDP is not rising, which is a good sign in all of these high-risk coronary obstruction cases. So this is a pre and post. 87 mean at baseline, decreased to 10. AR index good before and after. Case is done. And this is the last case I'm going to show you. Also a patient at risk for coronary obstruction, for left main obstruction with magna ease. At baseline, mean gradient of 65, AR index of, we have several numbers here, but it was a reasonable number at baseline. But unfortunately, immediately after doing aortic valve laceration, the blood pressure decreased. You can see also that on the screen. The AR index initially decreased to 10. So quick, I understand that I'm now in hemodynamic compromise situation after doing a leaflet laceration. I paced the patient, AR index improved slightly. I wanted to inject just to verify that indeed the AR increased, and obviously it's a lot of AR. I continue with the valve, and afterwards do also coronary injection to show that there is no coronary obstruction. The mean gradient is 12, AR index is 41. I decided to do post-dilation, not ring fracture, but gentle post-dilation, just to optimize hemodynamics. And these are this is the end result. The mean gradient decreased to 6, AR index is good, no coronary obstruction. The patient did well. So I'll summarize in one slide how I view the utilization of the wire. We have a lot of tools in the TAVI field, and to be honest, I'm really excited about our ability to do continuous hemodynamic monitoring during our TAVI procedures without having the need to bring back the pigtail. It really streamlines TAVI procedures and allow us to do them safe and effectively. And I think these methods can really support the ongoing TAVI revolution. So thank you very much, and I'll be happy to answer your questions.
Demonstrations of what this wire can do for you during your streamlined TAVI procedures. Maybe a last question for Herrier. How important are these hemodynamic assessments in a TAVI procedure? Do you do TAVI procedures without hemodynamic assessment?
Answer is no. In every case, we use it. And that's also the benefit that you don't need echo for most of your cases, if not almost all of your cases. So that's the largest benefit. And also, I think it's very important to say that we need to go to perfect results. And then we used to say always hemodynamics should be as good as surgical outcomes, but I think especially in self-expanding valves, we should do better. So, and we have to verify that, and we have to prove that.
Thank you very much. So I think with that, we are coming to the end of this nice breakout session. Let me summarize. I think this SAVI-wire technology definitely is an innovation that is relevant. It offers very easy and reliable pacing capability, so pacing on the wire. At the same time, you have this ability for continuous invasive hemodynamic monitoring, as nicely illustrated by Danny. And then in terms of stiffness of the wire, it is very competitive and comparable also to the competition out there. So I believe that we are looking forward to the introduction, the commercial introduction of this wire in also the European context. With that, I would like to thank OpSens for the support of this breakout session. I want to thank Ander and Danny for their excellent presentations, and also thank you, Herrier, for helping me during this breakout session. Thank you very much for attending this symposium, and enjoy TIO 2024. Goodbye.